or not, but when you're going back thinking of drainage, you also want to indicate how much drainage is present in a wound bed, and that's stuff that you've covered in fundamentals, but it's worth repeating. So your choices are normally scant, small, moderate, large, as far as your amount of drainage. Remember that? Okay, so when we are assessing our wounds, we want to assess if they are treated wounds or untreated wounds. An untreated wound is going to occur immediately after an injury. We want to look at the location, the extent of damage, note or assess for bleeding. If there's any foreign bodies in the wound bed, so it could be glass shards or dirt or grime or any type of foreign body. If there are any other associated injuries because of this wound, we would want to note them. And if it's contaminated, it would be considered a contaminated wound. A treated wound, we're also going to look at the appearance, the size, the drainage amount. Again, scant, moderate. It's usually scant, small, moderate, or large or heavy. If there's swelling present, if there's pain present, if there are drains or tubes present, and what the status of those drains or tubes are. So we want to make sure they're compressed. If it's a JP drain, note how much drainage is in that bulb. And if there is tunneling or undermining present. So as our treated wounds heal, the drainage should increase or decrease? Decrease. So if we notice a spike in drainage, like yesterday they put out 75 mLs on my shift, and now today they're pushing 250 on my shift, that's something that would be reportable to the physician. That's an indicator that something is not right there. It could be infection or it's something that needs to be addressed. Or if there are significant changes in their vital signs, we would want to keep an eye on that too. That could be another indicator that the patient is experiencing a contraindicated situation there. When we're changing our dressings, we want to look at the incision site, and we want to use clean gloves. Anytime you touch that area, we want to use clean gloves or sterile gloves, depending on the dressing change orders. When you assess your patient from this point forward, when you go to clinical and your patient has a wound somewhere on their person, you need to be looking at that incision, or looking at that wound site. So you might not necessarily be pulling back the layers of dressing, right? But you are looking at that area to see if the dressing itself is clean, dry, intact. If there is drainage present on the dressing, noting how much is there, scant, small, moderate, heavy. And then following up and looking at dressing change orders. So if you see a patient with a dressing on their person, you need to look in the chart and see about the orders for dressing change. Because we want you to be nurses, right? We want you to do something about that. You need to know what's going on with your patient. So you're not necessarily going to peel back the layers of dressing every time you assess that wound. Normally that does not occur unless you're actually changing the dressing, right? But you would assess what is in place. Right? If you don't look at it, how will you know if that drainage has now multiplied? Or because if you didn't look at it at the beginning of your shift, you're not going to have anything to compare it with, right? So when your patient has a dressing in place, you need to be assessing that. All right? Okay. Nursing process diagnoses. So what would our patients be at risk for? Infection. And the infection risk is greater if the skin impairment is severe. Their risk for infection is greater if the patient is immunocompromised, right? And they're also at a higher risk for infection if the wound was caused by a trauma or a traumatic event. Potential complication for our patient with risk for infection would be what? Impaired wound healing. Very good. All right. So when we're using our nursing process, our major goals, when we're planning our major goals, or my patient's outcome, what would be an outcome that would be important for your patients? healthy skin. So that another way we could say that is maintain skin integrity, right? I don't want their wound to get worse on my shift. Yes, ma'am.
You want to avoid further injury or infection.
Yes, prevent further infection. So outcomes for these may be patient will demonstrate progressive wound healing and regain intact skin within a specified time period. So if this was a short-term goal, something that's going to happen by the end of your shift, do you think they're going to get back all of their healthy skin by the end of your shift? Probably not. But would that be a long-term goal within 3 months or 6 months? Yeah, absolutely. Maintaining skin integrity is important, and then avoiding potential associated risks, so further infection or trauma to the wound itself. We want to set the patient up for optimal wound healing, right? So if the wound is somewhere where stressors can cause it to dehisce or eviscerate, we may implement interventions such as splinting when coughing or the use of an abdominal binder to help add extra support. So nursing process implementation. We want to facilitate wound healing. That's what every nurse with a patient that has a wound, we want their wound to heal to the best of its abilities. We want to set them up for success. We want to promote optimal nutrition and hydration. Remember, nutritional factors and dehydration can cause impaired wound healing, so we want to eliminate that. We want to prevent infection, and we want to position our patient to minimize the pressure that they're going to exert on that wound. Nursing process evaluation. Doesn't this just follow your nursing process all the way? Assessment, right? From assessment to evaluation. So expected outcomes. So we're going to evaluate our patient regularly during the wound healing process, and there's some expected outcomes that we're looking for. We want the skin and tissue integrity skin and tissue integrity is maintained. In other words, it's not getting worse. It's getting better, right? Maintaining that skin and tissue integrity. We want to see that the wound has decreased in size. Another expected outcome would be the patient would demonstrate an understanding of preventative care measures, or the patient has demonstrated an understanding and ability to effectively perform dressing changes if they're going to go home without home health care and they're responsible for their own dressing changes. So we would ask for a return demonstration. Teaching them simple to complex, right? Planning for discharge and follow-up care. When does that begin? When does that start? In the preoperative period or upon admission. The patient comes in from the emergency room, we're starting discharge planning on them already because we have to see the big picture and get all the pieces of the puzzle in order. So patient, we want them to be informed and prepared and gradually assume greater responsibility for self-care. So if they're in the hospital post-op day 2 and we know we're going to keep them at least another night or 2, we might begin to allow them to participate in their dressing changes and let us be the observer so we know that they are able to do that, right? Because we know, say for that particular patient, they're not going to have home health care nurses come, so they're responsible. We want to make sure that they're comfortable and are safe when providing dressing changes for themselves. Or if their significant other is going to be the primary caregiver during that time, we might have them help us have them show us a return demonstration of the dressing changes. We just want to make sure that they're going to be safe. Now remember, infection and delayed wound closure, the infection may not develop until the 4th or 5th post-op day, remember? So that's going to be something that's imperative that we communicate with our patient because they need to know that, hey, look for this around the 4th or 5th post-op day. And if you have infection, it might show up then. We're going to provide information to patient and caregivers, again, about the care of the wound site dressings, action and side effects of medications, and how to take them and when to take them, if there's any dietary restrictions or modifications. So if a patient has a large abdominal wound, they're probably not going to return to work super fast. And even then, they're going to have some limitations as far as what they can lift and activity restrictions, right? We need to make sure they understand the signs and symptoms to look for at home, especially in regards to infection. And then when to return for their follow-up appointment and where that follow-up appointment is. That's important information. We want to answer any of their questions and or concerns. We want to make sure that we give them written instructions for reinforcement. A lot of times patients do well to have written instructions to reinforce what you've been talking about. And then document and record those instructions in our patient's chart. All right? Okay, any questions for me? None? Okay, did you find out about the maggot?
No, ma'am. I just found like a whole bunch of research.
Okay. Jose had asked, how do they prepare the maggots for the procedure? I know they're sterile, but I don't know what the process is. He was going to try and look it up.
I had a wound care nurse actually explain that to my clinical group, and because she was using them at Chance.
Okay, so she saw it done at Chance?
I didn't actually get to see it done, but she explained the process to us. And they basically put them through this process to take away their like bacteria and stuff like that, while still keeping them alive, and it's like a complicated process. And then they put them in this baggie that's semi-permeable so that they can bite through the bag, but they don't escape out of the bag into the person, and then they double bag it and suffocate them when they die.
Good to know. One of my cohorts had said before, well, what happens to the maggots when they're done? Like, I think they dispose of them. They serve no purpose. All right, so get your devices out. We're going to play a Kahoot. If you've not signed in today, the attendance sheet is on that podium. Please make sure you do that before you leave. opioids for pain and has developed constipation. Good job. Increase fluids, use daily stool softeners, and ambulate. The RN knows the body's primary defense against microbes is what? Integumentary system. So the primary defense. Remember, anytime there's an incision or an opening, it creates a portal of entry for infection, for pathogens. The RN knows the inflammatory process may result in which of the following? Swelling, redness, heat, pain, loss of function. Very good. Which nutrients promote wound healing? Vitamin C, protein, carbon, and zinc. Where are you at? Thank you for your honesty. The RN knows what factor affects wound healing in an obese patient. Poor blood supply of adipose tissue, resulting in decreased oxygenation and delivery of nutrients. So, a lot of you picked uncontrolled blood glucose levels, which is a factor in impeding wound healing, but nothing in this question tells me that my patient is diabetic. Right? All I know from this little question is my patient is obese. Right? So with that, that's why this is the better answer. Because of the extra adipose tissue, and we know that there's not a rich blood supply to that area. Therefore, they're not getting the nutrients and oxygenation that they need as much as someone who's not obese. That affects their wound healing, right? Nap time, y'all have a lecture after mine, don't you? What do you have coming up? Obesity. Obesity. Right. The nurse identifies which factors that interfere with wound healing. antibiotics are all factors that interfere with wound healing. Which types of wounds take longer to heal because the healing cascade is not activated? Chronic wounds, very good. Remember, surgical wounds are considered an acute wound, right? If you think about the chart we went over. So surgical is an acute wound. With acute wounds, whether they're surgical or it's an accident, the healing cascade is activated because the inflammatory process is activated, right? So that's the first step, and then everything occurs from there. With chronic wounds, because they've been in place for so long, that healing cascade is not activated because it's something that's just the body is used to having for so long. Does that make sense? Yeah? No? What are we talking about? All right. The nurse knows the classification colors of a wound can be which of the following? Very good. Red, yellow, and black. Maggot is making a comeback with 3 in a row. Which of the following is a medical emergency? Evisceration is correct. What is dehiscence? So when the wound separates, and what's evisceration? You see organs protruding, right? What's delayed wound closure? What type of intention is that? Tertiary intention. And what would it mean if I had a saturated dressing on a wound? It is wet. What else? There's a lot of drainage, so I need some further information on that, right? Now that could be an indicator of which of these things. Evisceration. Well, it could be an indicator of dehiscence or evisceration, yes. If I have saturation, drainage on the dressing. There again, it's very important that you assess your patient's dressings from here on out when you have a patient with a dressing in place, so that you have a baseline for yourself. When cleansing a wound, the nurse knows it is best to clean the wound how?
Yeah, because it's the
From clean to dirty. What's the rationale behind that? So I don't want to further contaminate that wound, right? So I'm going to clean it from clean to dirty. Very good. The nurse knows to promote healing, a dry wound needs to be kept wet. moist, that's right. Now, depending on where they are in the healing process, doctors may come back in and say, okay, let's just leave that open to air. Usually they're farther down the line in the healing cascade. But for the most part, we want our wound beds to maintain moisture because that's going to promote optimal healing, right? Nope is making a comeback in the road. The nurse knows if a wound is excessively wet, they need to do appropriate dressing. Name a dressing that would be appropriate to use for drainage. Gauze would be an appropriate one, right? What's another one that we talked about?
The algae one.
Calcium alginate, right? That would be appropriate to use. Why wouldn't I use a heat lamp? I could burn the patient, right? I'm going to damage what I'm trying to do there. And we know that if they have excessive drainage, it's going to promote what? Bacterial growth and contamination. That's right. Type of drain that uses negative pressure to drain exudate from a wound. A wound vac. That's right. Where are my poor people that pick BP drain? That's not even a real thing. Hemorrhage drain is that little tube. Uses gravity, doesn't really use negative pressure. Wound vac uses negative pressure. And orthopat, which nobody's selected, is that mini cell saver that recirculates the blood, and then you're able to reinfuse it back to the patient. The nurse needs to choose a semi-occlusive dressing. Which one is appropriate? What's another benefit of the techoderm? I can see it, I can visualize it, right?
What was the tough one? Was that
Not inclusive.
not inclusive?
The RN knows a patient undergoing wound care is at risk for which complication? Infection, that is correct. They may have impaired mobility, but we don't know that for sure. We know that wound care is going to predispose them to risk of infection.
Please.
Nicely done. Clap for Christy. What questions do you have for me? Any questions for me? All right. So that is all I have for you. Before you go, do you promise that you will use this extra 20 minutes for study time?
Yes. For sure.
All right. If you haven't signed my attendance, please do so, and I will see you guys when I see you.
Love